Hello, and welcome to our webinar, Explaining SLT and the LiGHT trial. My name is Tom Bruner, and I'm the President and CEO of Glaucoma Research Foundation. Today, we have two very special guests for you. Dr. Inder Paul Singh, President of the Eye Centers of Racine and Kenosha in Wisconsin, and one of Glaucoma Research Foundation's ambassadors. Dr. Singh completed his residency at Cook County and his internship at Michael Reese Hospital, both in Chicago. He completed his fellowship in glaucoma at Duke University before returning to his hometown in Wisconsin. Throughout his career, Dr. Singh has been very involved in clinical research and has dedicated his work to improving the lives of glaucoma patients. Dr. Singh will be joined by Dr. Gus Gazzard. Dr. Gazzard is the Director of Glaucoma Services at Moorfields Eye Hospital in London, Professor of Ophthalmology and Glaucoma Studies at University College London, and Chief Investigator of the LiGHT trial of laser treatment for glaucoma. He received his medical degree from the University of London and did his initial medical training at Corpus Christi College and Cambridge University. He completed his ophthalmology training at King's College Hospital, St. Thomas Hospital, and Moorfields. It is my honor to welcome Dr. Singh, who will speak first, followed by Dr. Gazzard. And after the presentation, we'll have an opportunity for discussion and to respond to some of the questions that were submitted. So may I introduce Dr. Singh?
Well, thank you so much, Tom, for that introduction. It is an honor to be here. Hopefully you guys can see me okay. I am excited to talk to you about a topic that I've been very passionate about, and it's also an honor to be speaking alongside Gus Gazzard as well from the UK, who's, as you'll hear, has done so much great work on laser trabeculoplasty. But basically, for me, this has been something I've been doing for many, many years. And as we'll talk about, there's such a need to understand how difficult it is for our patients to take topical medications. We understand glaucoma, as we'll talk about, is a condition or a disease where we're trying to help protect the nerve in the back of the eye from getting worse. And one of the most common ways we do that is bringing the pressures down or controlling the pressure in the eye. And although drops have been a mainstay for treatment for many years, I think now with other technologies like the laser trabeculoplasty we'll talk about, we have an ability to not only get the pressures down, but also maintain high quality of life. And that's something that we're going to talk a lot about today as we go along with the slide deck here. So with that said, I'm just going to go ahead and just move forward here. And I'm from Wisconsin. Yay, I'm a cheesehead. I have my Green Bay Packers. For those of you who like football, I'm a big Packer cheesehead fan. And I also love, if you ever have a chance, come visit Wisconsin in the summer. We're actually getting past the summertime now, but we love our beer, our cheese, our lakes, our deep fry, everything. And of course, we love our Wisconsin football as well. And I just want to give a little credit and honor of my father, who I joined his practice after a fellowship. He was my mentor in so many ways, taught me so many things about ophthalmology and eye care that I never would have learned outside of him. And that was on the left is the first day I kind of took over the practice, and then the right is the last day we were in surgery together. And his comment to me was, Paul, never be complacent. Keep finding ways to make our feel better, to hopefully improve our outcomes for our surgeries and outcomes for our patients and quality of life. And so this is kind of the same vein of what we're seeing in glaucoma, this constant evolution of helping improve our patients' quality of life, as well as protecting people from going blind, which is why I'm so involved with the Glaucoma Research Foundation. I have 3 kids. I love talking about my family. I will say, all those who are out there who have young children, make sure you spend time with them. Life is about a balance. And I tell you, it just takes a couple minutes. Next thing you know, your kids are all of a sudden grown up and almost going to college now. So it's scary how fast they grow up. But they're the great equalizers of life. No matter how good your day was or how bad your day was, they kind of equalize things for you as well. And I am in a band. I think it's so important for all of us to have an outlet. For me, music is my outlet, and I'm in a band called Funkadesi, which mixes Indian funk and reggae, kind of a world beat type of music. And it's helped me understand how much more that binds us than separates us, regardless of economics, race, religion, and education. We all look at each other as equals. And I think that's part of what I believe when I kind of look at my patients as well. And I think this is kind of a video of me on stage live, jamming with the band as well. But I also want to give a little shout out to Gus Gazard as well, who's, he's a very famous guy. And I was in my practice the other day, and all of a sudden a patient comes in with a t-shirt of his. And I was like, really? He's pretty famous. Not just the UK, but here in America as well. So just want to give him a shout out there. Not just famous there. I was getting coffee at Starbucks, and all of a sudden I'm like, oh my God, he has his own coffee mug too. So he's everywhere. And then I was at dinner with my wife, and I was like, okay, let's have a glass of wine. And so give me your best bottle of red wine. And of course, what comes out is Gus Gazard's wine. So he's definitely a famous guy. But what he's done for SLT with the LiGHT trial, and we'll talk about, is really changed a lot of paradigms, a lot of perceptions of laser trabeculoplasty in terms of doctors who now feel more comfortable using it as a first-line treatment, which I'll talk to you a lot about as well. But back to eye care and back to glaucoma, which is why I know you're allowed here. You guys are all here. To me, it's all, again, unfortunately, the only way we have to truly stop progression of glaucoma, to protect your vision, is to help bring the pressure in the eye down. Glaucoma is a condition where the pressure in the eye goes up or is too high for that person. It could be, everyone's different in terms of what pressure their eye needs to maintain or to protect them from getting worse. But at the end of the day, it's all we can do right now is protect you by lowering the pressure in the eye down. It's the only risk factor that we can treat. And the reason why the pressure goes up, I always tell patients, the eye is like a water balloon. So the eye makes fluid to keep the shape of the balloon, right? But the eye continuously makes fluid to keep that shape of the eye. Well, there's a drainage system, a little meshwork here, the little pores, little dots you see there. There's a little pores, like a little meshwork of like a sponge, where the fluid drains out of the eye. And what's happening, a lot of our glaucoma patients, is the disease, what's causing the pressures to go up in a lot of our patients, we think is happening, a lot of it, at least, is at the level of that trabecular meshwork. Those pores are getting kind of closed up. And when those pores get closed up, the pressure goes up because the fluid can't leave the eye. Kind of like a water balloon getting tighter and tighter. It fills up with more fluid, and that's happening in the eye. So you want to bring those pressures down by hopefully opening up the drain, right? That makes sense. Let's open up those pores. And that's what SLT does. And we'll talk more about that, kind of the mechanism of how it works as well. But before we had SLT, for a long time, all we had, and all we still have for a lot of our colleagues, is drops. And drops do work. They do work very well, actually, by decreasing how much fluid the eye makes, or by helping open up different channels for the fluid to leave the eye. But drops can be really difficult to take for a lot of different reasons. And if you think about why, for us as providers, it's frustrating because we don't know if our patient's taking medications. Did they forget to take the medications? Or is it cost too much? In America, at least, the cost is significant for a lot of these brand name medications that we prescribe. Or patients have issues like comorbidities. Some people have dry eye, we'll talk about, that can make it difficult to take these topical medications with preservatives in the eye. Or a lot of times you have issues of just redness in the eye. A lot of these medications can cause redness. So although drops are easy to take sometimes, they can be difficult long-term for all these reasons that you guys out there, I'm sure, have dealt with as well. And I've had experiences where I've asked my patients to take medications in my office, and it's scary what they'll do to actually take their medications. It's kind of frightening. So I always say, Mrs. Smith, let's just say, here's an artificial tear. Take the medication in front of me, see what happens. And it's scary how it's difficult for a lot of our colleagues and our patients, rather, to actually take medications. It's not easy. And it's important to recognize only 5% of the medication that you put in your drop in your eye, only 5% of that medication actually gets into the eye, to the tissue that we need to get to. A lot of it gets absorbed in the lids and the white part of the eye, or the conjunctiva that covers the white part of the eye, or goes through our gland by our tear duct into the back of our throat. So all these reasons why not a lot of drug is going into the eye. So we need a lot more concentration of drug to get into the eye, which causes a lot of side effects of the surface of the eye as well. And one of those side effects, to me, that I've seen a lot is dry eye, a significant, what we call comorbidity, meaning a lot of patients who have glaucoma tend to have dry eye. And it's because of the age. As we get older in life, we change our glands and our hormones that produce oils. So dry eye is a risk factor as you get older. But when you have glaucoma drops, when you're putting drops that have preservatives and the chemicals in those drops itself, they can cause more dry eye issues. And if you look at data out there, up to 50 to 60, probably 70% of my practice patients have dry eye at the same time of glaucoma. And why that's so important is because a lot of you out there who have dry eye may be blaming your glaucoma drops for your symptoms of tearing or burning or vision coming and going or redness. And if you have glaucoma drops that have preservatives or even the chemicals in there, and you have a dry eye, those glaucoma drops can make it worse. They don't always cause dry eye, but the glaucoma drops can make things worse. And so people care about symptoms. So one of the most common symptoms that we found is vision coming and going. If you say, Doc, guess what? My vision comes and goes every time I blink my eye. That's usually an unstable surface, what we call tear film that we make. Or if you're saying after reading for 5 minutes, I just can't see anymore. I have to blink my eye, go away, and come back and I can see again. That is a surface issue or dry eye related issue. And when I hear patients like that, my first goal is to get them off the glaucoma drops to see if I can decrease all the toxicity of the medications that can cause more dry eye. And we do have great data out there that supports that the more bottles we add to the surface of the eye, the higher risk we have of developing a dry eye. And look here, in 3 bottles, you have 60% in certain study, a study of 20,000 patients in Europe, showing us significant correlation of drops that we add, bottles that we have, as well as dry eyes. So we definitely want to limit that. And why this is important is because studies have shown us, a doctor out in Europe also, Boudouin, has shown us that when you have dry eye at the same time of glaucoma, your compliance, your ability to stay on the medication long-term goes down by 30%. It's just so hard for patients to take drops. And I'm sure you all know out there how difficult it is, especially if you have those symptoms of dry eye. And what it looks like to us, to me, is when you look at this filter, the green, see those little black dots on the surface of the eye here? Right, the green filter there, those little black areas, that is a filter we use to help identify the surface. And see how there's all those black areas? Those are all missing tears, missing film that covers the eye. And that will cause your vision to come and go, cause blurry vision, sometimes some pain, redness, and even some tearing and burning. So these are things that we can see as eye doctors as well. And sometimes we get so busy with our glaucoma pressures that we sometimes forget to take a look at the surface of the eye. So a lot of patients go to their doctor's offices and their doctors say your pressures are great, but your main concern is your symptoms of dry eye. And that's what we can't forget. And there's also some bumps on the surface of the eye there as well. And a couple more slides here on this, but I think it's important to recognize when we have dry eye, we're not compliant. If you're not taking your drops every day like you should, right, for different reasons like we talked about, it can cause your pressures to go up and down, which can lead to potential for getting worse. And studies have shown that the more your pressures go up and down, the more risk you have of glaucoma getting worse. That's what the slide is showing us here. And that's why it's important to minimize the fluctuation in your pressures, keep it more stable. And if you're not taking it every day, that can be a risk factor as well. So when I look at myself and I think about when I'm prescribing drops to my patients, I actually had to reassess many years ago the idea that drops are actually safer than procedures. Now we think of, doing a procedure as more kind of having more risk to it. But actually, when you look at the SLT data, and I'm sure Gus is going to talk to you about that, we realize how safe this beam of light treatment is, this laser is. And he's going to talk about SLT. And if you think about the drop related issues, whether it's allergic reactions or redness, sometimes we lose with the drops. A drop that we give commonly is something called latanoprost. A lot of you are, I'm sure, on that class of medications. It's a wonderful drug. At nighttime, you take it once a day, and it does help bring the pressures down. But it can cause us to lose some of the fat around the eye. It can cause the glands in our lids to not be as healthy, and it can cause allergic reactions, redness. It can cause our lashes to be too long in some patients. So there's a lot of risks with drops. Although they seem safe, it's not always kind of what we call benign. There are risks with drops as well. And so when I look at glaucoma today, and I think I have a patient like you in front of my chair, I look at, is the pressure where I want it to be? Are your nerves looking good? Is your side vision test, that visual field, looking stable? Still the primary definition of what we call control of your glaucoma. But I also look now at what's the quality of life. If you have a difficult issue taking medications, it's costing too much, you can't remember it, physically you can't take the medications, that is not controlled glaucoma. So here's a patient who I had not too long ago where the pressures were great, the side vision test, the visual field looks stable and pretty healthy still, the nerves look good, but the patient looked like that. To me, that is not controlled glaucoma, because I don't want to make a patient suffer for the rest of their life looking like that with the crusting eyes and red eyes as well. So that's been the big change. And so it's important for us as eye doctors to kind of ask our patients, and for you to tell your doctor, if you're saying to me, I need samples every time I come in, or your vision comes and goes, or you just can't remember the top color, that means you're probably not taking the medications. And we have to be aware that a lot of our patients are in that boat. And so the new paradigm shift in glaucoma to me is the fact that we can now keep your quality of life high, and we can also control your pressures at the same time. That's why there's been such an excitement of all these new technologies like the laser we're talking about today. Or we can address the issue of compliance, meaning making it easier for you to be on your medications or stay on your therapy, and as well as maintain a high safety while we're trying to address those issues of compliance as well. That is really the nutshell what has changed in glaucoma. And so it's not about drops now. We have laser, we have other surgeries that we can do, and we have things like drug delivery we're not going to talk about today. But the laser is a great first line treatment. And Gus is going to talk to you more about the LiGHT trial. I'm just going to go through some basic, the next few minutes, some basic understanding of what trabeculoplasty is all about and what we do. Now, remember I told about those pores on the trabecular meshwork, those little pores getting blocked so the fluid can't leave the eye? Well, that's what's happening. So what the laser does is it delivers a beam of light. And I always tell patients, this is not a destructive laser. This doesn't cut or destroy tissue or cause scarring. This just excites the tissue. It just stimulates your own eye to release your own enzymes to naturally rejuvenate. You're actually literally rejuvenating and opening up those pores naturally. And so it's a beam of light that evenly distributes this energy. And that causes you to release your own enzymes that opens up those beams so the fluid can leave the eye better. That's the premise behind it. So I use the word to my patients all the time. It rejuvenates. It's in the office. We can do it in the office. You don't have to go to the hospital. It's not a surgery where you have to do pre-op labs or x-rays or physicals. You walk in, walk right out. And because it's covered by insurance, a lot of times it's cheaper than even topical drops, even generics. And it's enhancing your natural drain. It's enhancing what your body does naturally. So we're not altering how your eye works. It's actually helping you produce or helping you function in more normally that you should as well. So it's the most, I think, natural way. I'm going to skip some of these slides here because I know Gus is going to talk about the LiGHT trial. And there's some other studies that we can talk about, but I'm going to fast forward to this and get to some of the ending slides to stay on time here as well. Just want to show you what it looks like. That red beam of light, this is what it looks like to me as a doctor and to us as a doctor here. We have a red beam of light there, and we're focusing that beam of light on that brownish line that you see there. That is the drain. And we focus that beam of light, and we're just we go click, 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 and we're just stimulating that drain to release its own enzymes. So that brown line is what the drain looks like to us with that little lens as well. And it could be for a number of different kind of patients. You could have early glaucoma. You could have something called ocular hypertension, where your pressures are high, but you don't have any evidence of glaucoma yet. This is a great opportunity to get your pressures down, open up the natural drain, not have to worry about taking drops for a long time. We also have other types of glaucoma this can work in as well. So there's a lot of opportunities for a number of patients. The risk is very low. There are a little bit of risks like anything we do, but they're very low. The main risk I tell patients, it doesn't work for everybody. But 80% of the time, it's going to work for you. But 20% of the time, it may not give the effect. But if it doesn't, we can always start drops or do some other procedures if need be. Sometimes the pressure can go up transiently for the first few hours or first few days, and then it comes back down again. And sometimes you can get some localized inflammation, which we give some drops. And I know Dr. Gazar is going to talk to you about some drops we can give for a few days afterwards as well. But very, very few really significant side effects as well. So for me, it's my first line. For me, if I have a patient coming in for glaucoma or high pressures in general, if they're a good candidate and I can see that drain really well, I do offer this as first line. I think it does decrease the issues of compliance like we talked about. We are rejuvenating the natural drain, and we save the eye for drops if need be later on. And we can supplement the pressure by using drops if we need to as well. So with that said here, I've just a couple more slides here. I think cost savings is significant. And like I said, some of these drops that we give, even with insurance, can be $40 to $60 a month for a lot of the brand name medications. And if this laser can last you a year, 2 years, 3 years, as he'll show you with data, studies can show it can last longer in some patients, 3 to 5 years. And you can repeat SLT over time if you need to because it's non-destructive. So we can save a lot on costs as well. And there's been a number of studies showing us a few $1,000s over a few years you can save depending on your insurance and kind of what location you're in and around the world as well. So I'm just going to fast forward through a couple more here things as well. But in general, I want to stay on time. So we have about 15 minutes to talk about it. But that was just an overview of kind of why SLT, this beam of light, is a good opportunity for us to help you out. And I'm going to kind of stop there and let Gus talk about the studies that show us the data and kind of how to manage it post-treatment as well. Thank you so much for the opportunity.
Thanks very much. I hope you can hear me now. Gus here from London. Thanks, Paul. That was a great introduction to SLT laser, a great overview of why we're doing it and some of the how. So really helpful to introduce the LiGHT trial. So I'm very specifically going to be talking about the trial that we conducted here in the UK. and a little bit about why we did it, but mainly about how we did the trial, and then what data we've got from that and what the findings are from that. There are no scary pictures. There are sadly no pictures of Paul on a bottle of wine, but it's nice to know that, you know, I've got some good quality red named after me. We will just move on. I do have some funding acknowledgements from people speaking, but mainly I want to thank the trial study group before we start, but particularly to thank the 718 patients who were in the trial and were willing to be randomized. They trusted us to accept that when we started the trial, we didn't know the answer. We didn't know whether drops or laser would be better, which was why we did the study. And they were willing to be randomized, that is, chosen for one group or the other at the toss of a coin, metaphorically. So what we're talking about is the LiGHT trial. And the first 3-year outcomes for this were published back in 2019 in the Lancet, which is, you know, I'm very proud of, because it's hard to get something in the Lancet, and it was a mark of quality of the study, really, and of the effort that everybody put into really making it work as a study. And I'll explain a little bit about why I think we've been able to change treatments around the world on the basis of this study, because we also have to remember that laser's been around for a long time. Trabeculoplasty's been around for over 30 years. SLT, selective laser trabeculoplasty, has been around for around 20 years in some shape or form, and yet it took a big trial with a lot of work to really convince people how well it works. So we call it the LiGHT trial because it was SLT and laser and glaucoma and ocular hypertension. And we conducted it as a health-related quality of life study, as that is the main outcome. And we compared 2 treatment pathways. So we didn't just do laser versus an eye drop. That's been done. What we did was laser first versus medication first of patients, and this was the crucial thing, patients who hadn't been treated with other things for many, many years. And I think that's why the results for this treatment were so good, is that, and we'll come to this, is that we were treating people who were newly diagnosed right at the beginning, for most of them, of the course of their disease. And this was initially a 5-year study. It went on to become an 8-year study in total. We had 718 patients across 6 centres around the UK. And we, as I said, we used newly diagnosed, treatment naive, so not previously treated patients. And we had the health-related quality of life through questionnaires, asking patients how they did, but then also clinical outcomes, pressure control, disease control, the things that we as doctors ultimately worry about. Do the patients need extra medication? Are they going to need more surgery? And it was a very carefully conducted, well-managed study with very broad inclusion criteria so that it would be widely applicable to most of our patients. We had a range of races from across London, across the country. We had a range of ages, a range of eye pressures, and primarily they had open-angle glaucoma, and some of them had ocular hypertension. And we set a target, a target pressure, and we aimed to try and get to that target pressure. And that's what we do in clinic. We call this a treat in pursuit of target design. But what we did was to set a target and aim for that. And we had 91% of those patients still in the trial at 3 years. And we had some decision support software that we wrote for the study that was able to guide our treatment so that we could reliably be certain that the guys in Belfast and Yorkshire and London and Norfolk were all doing fundamentally the same thing, and we weren't diverging. We had a good broad oversight of what people were doing and how we were treating our patients in the study. And then we had some very specific criteria for when we gave drops or when we gave more laser. And we defined very carefully what that target pressure needed to be and what the definition of the disease getting worse would be. Lots of things that make the study a very well standardized study that you can go in, look at the nuts and bolts and work out whether you believe in the findings at the end of it all. We published all of this, and this was predetermined and out there for people to scrutinize before we published the actual results. We standardized the laser protocol so that it was exactly the same laser across the whole of the trial. Not all studies, you think that would be obvious, but not all studies do that. We treat all the way around 360 degrees with 100 shots using a standard lens. We had a defined clinical endpoint. We trained all of our laser observers, and we gave some non-steroidal anti-inflammatory drugs at the end, but only if the patients had significant pain. And we also allowed them to repeat it. This is a slide we're very proud of because it showed that our predictive cumulative target was very close to what we achieved, and that we managed to recruit all of those newly diagnosed over 700 patients in 2 years, which at the start of it, a couple of people thought we weren't going to be able to do. Not only that, we managed to hang on to 91% of those patients at the end of 3 years. What were we looking at? Well, 3/4 of them had glaucoma, primary open-angle glaucoma, POAG. The rest ocular hypertension. Of those, they were relatively sort of mild to moderate disease. So people really very much at the beginning of their disease journey. We randomized them into either laser first or eye drops first. And then once they'd had either their laser or eye drops, we monitored them to see if they got a good enough pressure. And if they didn't, they had another laser in the main, or they had extra eye drops. And if they really continued to get worse, the laser group could then start eye drops on top of that. So if the laser didn't work at all, they got eye drops. If the lasers weren't strong enough, they got eye drops. Now, in this sort of study, we can look at how well the pressure reduces immediately. And it was very similar between the guys having medicine first, prostaglandins, and the people having laser. So the laser was working about as well as a prostaglandin. The number of visits that were actually at target was slightly higher, but really in the laser group, but really pretty good. These were very compliant patients taking a lot of their drops, at least before the clinic appointments. There weren't any cost barriers to participation because all of this healthcare is paid for with their taxes. We then looked at how whether they got worse based on their peripheral vision or their optic nerve pictures. And we found that there was a small but significant difference at 3 years where the medicine first was getting slightly worse at a greater, faster rate than the laser first. Now, cataracts were comparable between the two groups. Trabeculectomies, however, this is one of the traditional surgeries for glaucoma that's getting worse and can't be controlled with laser or drops. That was, in the first 3 years, much higher rates within the medicine group. So the eye drops group had 11 trabeculectomies, whereas the laser first group had none. And remember that if these patients aren't controlled, they're getting more treatment as we go along. So it's a treatment pathway, it's a treatment journey. And these sorts of escalations were more in the medicine first group. So we weren't managing to hang on to or control that pressure as well in the group that were having laser. In the group that were having eye drops. But what's exciting about the group that had laser is that if you look at their eyes and how well they were controlled with just laser, so how many of them needed no drops at all at the end of 3 years, we had 78% of these eyes controlled with just laser, needing no medications whatsoever. Now, this was really staggering. We were really surprised by how high that figure was. But it showed that if you treated patients with laser first, that you could get over 3/4 of eyes, or around 3/4 of patients, who would be controlled and drop free and at their pre-specified, really stringent target pressures with just laser. We weren't looking for a just 10% reduction in eye pressure. We were looking to say, right, this patient's really badly affected, so they need a lower pressure. This patient's less affected, they need maybe just a 20% reduction in pressure. And this patient needs over here, needs a 30. We tailored these pressure targets to the individual eye of the individual patient based on severity of disease, how bad the eyes were affected, and where their pressures started off at. 3/4 of these eyes had needed only one laser to remain drop-free. So many of these eyes, these patients had eyes that were still controlled at 3 years and carried on being controlled. And we'll come to see the 6-year results in just a second. The safety was incredible. We had one patient with a pressure spike who required treatment out of 776 lasers over the 3 years. If we look at the 6-year results, those figures continue to hold out. So this is really exciting. This is just published this week in Ophthalmology. And around 70% of patients who had the laser first, 70% of their eyes could be controlled at target without medications, with just laser and no surgery. I don't really consider laser surgery. It's done as an outpatient, as a clinic-based procedure. It just takes 5 or 10 minutes and is pretty much pain-free. So 70% of those eyes were controlled after 6 years without any eye drops. The drops first group did have some that were controlled, but those eyes were all people that had, at the 3 years, had gone on to have laser. They were allowed to cross over into the laser group for a variety of reasons. We didn't feel it was ethical to withhold laser once we knew it was working so well. So in the drops first group, we had a number of people who said, actually, I'm fed up with my drops, give me some laser. And in that group, it worked extremely well, which is why we have some patients at 6 years who didn't have any medication in the medication group. We also looked at how bad the eyes got, how many eyes in each group were getting worse, so-called disease progression or deterioration. And we found that in the drops first group, the red bar on the left of the screen, over a quarter of them over 6 years were getting significantly worse. Whereas in the laser group, it was around about 20%. Now, remember that we're treating to a preset target pressure for each eye. So on average, these eyes are all going to be treated down to the same level of pressure because we're watching them very carefully, we're looking after them very carefully. And despite that, despite catching them getting worse and therefore giving them more treatment, the eyes, the patients that had laser first, managed to do better with less disease progression, less deterioration of their glaucoma, even though we're watching them carefully and giving them medication when they needed extra medication. So that was really exciting. You can look at disease control, glaucoma control in over those 6 years in other ways as well. If you look at the rates of disease progression, as I said, that was significantly different between the two treatment arms, but you can also look at the rates or time to requiring glaucoma pressure controlling surgery. And in the trial, we specified in the main trabeculectomy as that surgery. And the drops first arm, in the blue line here, they're hitting surgery at a faster rate and continuing to diverge from the laser first group, showing that the laser first group had greater protection of the eye, greater control of the pressure, greater prevention of disease deterioration, even though we're trying to treat both groups the same in terms of pressure reduction. There's a lot of data in the trial, there's a lot of data in the papers, and I don't want to get into too much detail of too many of these papers. There are a couple of things that I'd just like to draw out. One is the question we always ask is, can we repeat laser? So we decided to do analyze some of the data that we had to look at a retreatment analysis. And what we did is we looked at eyes that had failed treatment, their pressure had risen again, or the eyes had never responded. And we looked at those after they'd had a second laser. And what we saw was that initially, by definition, we're taking eyes that have failed. So the proportion that were at their correct pressure drops and drops and drops. So the blue line trends down towards 0 because they were uncontrolled by definition. But then when we looked at that same group over the following year and a half, after their repeat laser, the rate at which they failed was much less. There was an initial reduction. Some of them, it didn't work. But then after that, those same eyes after their second laser did much better. So in fact, retreating them with laser actually meant that they did better for longer the second time. So repeat treatment, redoing the laser is well worthwhile. So successfully reduced pressure in many of those patients who had initially failed. And it also lasted longer than the initial repeat treatment. And it wasn't linked to when they failed. So if they failed at 2 months or 6 months or 18 months, we saw the same kind of reaction, the same kind of proportions that were controlled after that. So that was another thing that was able to influence practice. And that was one of the big things that changed how I was delivering laser and to whom. We also did some very detailed visual field outcomes, quite a technical analysis, but we essentially took over 11,000 visual field tests from the 688 patients for whom we had data for this. And we compared the two groups, the medication first group and the laser first group. Now, remember again, I keep saying this, but remember again that we aim to treat these eyes to their pre-specified target pressure So we took a patient and we said, right, you need to have a pressure of 18. On another patient's eyes, we said, well, you're not so bad, so maybe you'll be okay with a pressure of 90. But we pre-specified and preset that target, and then we aim to meet it with laser on drops if necessary in both arms. So laser first could have eye drops. And yet, despite that, we still saw a difference in the rate of the visual field deterioration in the group that had worse visual field deterioration in the group that had eye drops first. There are various explanations for that. One is about the fluctuations in pressure that you may get with medication may be greater than you do with laser. And the other is that it may well be that not all patients remember to take all of their drops all of the time. Remember that these patients aren't paying anything for these drops, so it's not a cost thing. It's just whether they're remembering or whether they're getting it in them in okay. And as Paul explained, we know that that's not easy for a lot of our patients. And so laser that you have once and forget about takes away a lot of that need to remember, the compliance with the medication, and takes away a lot of the barriers to using pressure lowering treatment adequately, because it's done for you once, not forever, but it's done for you once in clinic, and then you have the regular checkups. Now, sometimes you need to top it up with medications, but even when that happens, you're using fewer medications than you would have done otherwise. So there's good reasons why it may be giving you better pressure control. We also did an economic evaluation. This applies specifically to the UK, but fundamentally, we were showing that doing laser was at least £3,000 cheaper for the healthcare system. There are still questions that remain. How often, when should we repeat SLT? Can you do it twice or 3 times or 4 times? What's the best endpoint for the doctors? How do we tell we've done enough when we're looking at that laser? Could we do better with the drops that you use immediately afterwards? And, does laser work as well if you've had drops for many years beforehand? We've mentioned harms, and Paul's mentioned that there are some rare side effects and harms that can occur. We have to count those and be aware of those, but let's not forget, and he explained very nicely, I thought, how actually, medications themselves are, in a large proportion of patients, causing often unrecognized problems. And perhaps are there racial variations in response? Are there some people in whom they don't work as well, or does laser work as well in people of African heritage, for example? And I was very delighted to be asked to collaborate on Heike Philippin's study, which was conducted in Tanzania, in Kilimanjaro, and they compared an SLT group with simple timolol, a beta blocker that's widely available there. Many other drugs are too expensive. And they showed that the timolol group fared less well than the SLT group. The SLT group had better pressure control than did the eye drops. So in this African population, laser did very well. We're doing a similar study to the LiGHT trial, like China, where we've recruited now over 700 of the patients in Guangzhou. We're waiting for to see the outcomes of the follow-up there, COVID permitting. There are some harms. Sometimes the cornea can change very slightly. Sometimes there are subtle shifts that you can measure. But in terms of measurable problems with vision, very, very few. Whether or not we should repeat it, maybe even annually, is a subject of a huge trial that Tony Riolini is heading up in the US, funded by the National Eye Institute with over $15 million of research money. And Moorfield is one of the recruitment sites for that. And they're doing a very interesting low dose treat once every year in, year out, because the idea of regenerating trabecular meshwork cells, perhaps stimulating stem cells to divide, means that we just need to tickle up the stimulate that trabecular meshwork every now and again to keep it going through a sort of physiological tissue response. And that may be all many of our patients actually need, which would be very exciting if that's the case. And lastly, just to leave you with a look into the future, possibly direct laser trabeculoplasty, where you don't even need a lens on the eye, is probably coming to a clinic near you very soon. There's a randomized controlled trial comparing that with standard laser, and this will be very exciting, particularly around the world outside of Western healthcare, where people don't necessarily have access to an ophthalmologist, and this could take SLT much further than standard SLT is available to patients. So I will leave you with a final slide, is that, you know, some of my thoughts on what we should be doing as a result of the LiGHT trial. Really, I think we should be offering it to all newly diagnosed patients as a primary treatment, considering it as a replacement treatment for anyone who's perhaps not happy, remembering that it can be successful with the repeat treatment. But if you're on multiple medications and it's still not controlled, then you may well want to consider progressing on to the next stage of the treatment ladder and hierarchy, and some form of minimally invasive glaucoma surgery is probably what that particular individual needs. And with that, I'll leave you there. Thank you very much. Just to say that in the UK, the NICE guidance, which is our sort of National Institute of Clinical Excellence, has now decreed that we should be offering it to everyone, and that's the obligation now for clinicians in this country. The European Glaucoma Society and the American Academy of Ophthalmology practice patterns have both saying that it may be used as an initial primary treatment, which is something that 5 years ago they certainly were. So it's been, you know, an exciting journey, and there are still things for us to answer from now on. But I think now is a good time to stop and hear if there are any questions. Thank you.
Thank you, Paul and Gus. Both of those presentations were just fantastic, and you made it so clear and so easy, I think, for everyone to understand. And we do have quite a few questions, and I certainly want to thank everyone who has submitted a question. And I guess I had made notes myself of a couple of questions I wanted to ask to sort of start our discussion. And frankly, I keep coming back to the same question, which I didn't even have on my list, which is, so why aren't we using SLT? I mean, what's your take? I'd like to hear from each of you. What's the holdup?
Well, I can give you my perspective here in the United States. I think that a lot of it, you know, it's hard to change practice patterns. You know, as eye doctors, as ophthalmologists, we get into our rhythm, and we you know, what's our comfort level. And anytime you're changing paradigms and you're changing the way we approach a condition, it's just hard to change the idea. And, you know, historically, it was drops. And we did surgeries or procedures when it was more advanced because the risks were so much higher. And when the initial laser trials came out back in 30 plus years ago, they were done for more advanced patients a lot of times. So we reserved laser trabeculoplasty, something called ALT many years ago, for those more advanced patients, and where it wasn't quite as effective as we're seeing now in earlier patients. Plus, lasers initially many years ago, before SLT came out, it was a one-time thing. We used a different laser called an argon laser. You couldn't really repeat it again and again, so you kind of reserved it. And so I think now we are seeing earlier data showing earlier, as Gus mentioned, we see patients who are mild to moderate, even ocular hypertension. We see better longevity, better chance of it working when your eye is not scarred down. Because remember, when you're on drops for so many years and so many years and so many years, there's a theoretical chance that you're actually causing more scarring of the drainage system. So if you do it earlier, when you have a healthier, what we call distal channels, long story short, the whole pathway is not as scarred, you have a better chance. So long story short, I think it's the mindset that we have to get used to. Hey, doing a procedure is okay. It doesn't have to be for something we have to wait for. Number two is that because it's a different laser, we can repeat it now. And it's just getting doctors to feel comfortable offering that and explaining to patients, because we assume that patients want drops first. We assume that they're scared of having a laser. But when you really talk to patients, you realize as long as they understand what they're getting, there are more patients who say yes to the laser than say no.
Gus, what's your take?
I think the biggest barrier is changing people's behaviors.
And by that, sorry to interrupt, but the doctor's behavior or the patient?
Doctor's behavior. Yeah, sorry, doctor's behavior. changing what doctors do is notoriously difficult, even in the face of evidence. We are all creatures of habit. I think what is exciting is that we all dislike a lot of the side effects from medications that we see, and therefore I think the time was right really for the study to say, well, come on, let's be doing more laser. And I've ended up putting a lot of effort. I don't want to be selling laser. I don't want to be the guy that's constantly plugging this and saying, come on, we've got to be doing more. We've got to be doing more. I want to say, right, let's look at the evidence and let the evidence tell us what we need to be doing.
Absolutely. But so, I mean,
but I think the evidence shows 70% of people, 70% of eyes anyway, at 6 years are controlled with just laser. And that for me really is a no-brainer. I didn't get involved into the techie theories around mechanism and stem cell proliferation that may be occurring. We don't know. We do know that there are some pretty exciting histological changes occurring in some of the animal models with both kinds of laser trabeculoplasty, the old-fashioned ALT and with SLT. And that means we may actually be rejuvenating the very cells that keep that meshwork alive, keep it functioning, keep it working, keep it controlling the eye pressure so well. And that's why, I mean, I think the COAST trial is going to be exciting for that reason. But even without that, just the very fact that you can do a couple of lasers for the majority, 1 or 2 lasers, the majority of patients at 6 years who were controlled had only had 1 or 2 lasers. And you know, you can do that and keep people off drops for many years. And I like Paul's point about removing potential exposure to dangerous drugs that may cause scarring of downstream pathways, particularly if they're preserved with benzocaine chloride.
Yeah.
You know, Tom, you know, one of the kind of realizations I had after COVID was, you know, how we do minimize the kind of effect or the impact of poor compliance. You know, because of COVID, a lot of our patients didn't come in initially for the first year plus after COVID, you know, and when patients ran out of medications, they didn't get their refills, or they're having issues where they just stopped on their own. And unfortunately, there were patients who got worse, you know, when they finally came back in, and we were thinking, oh my God, it kills me to say that I could, you know, if they had a laser, at least I would know there's some effect without them having to come in. I have more confidence versus they'd run out of medications, they can't get the refills, or they're having some problems with it. So we realized that compliance is something that we, I think, have underappreciated in our profession, at least in my opinion. And I think now we're starting to see more data in the MIGS world, the glaucoma surgery world. We're seeing data coming out showing that, you know, despite the same efficacy, so in the Gus made a great point, SLT versus drops, the same pressure reduction for the most part. One group had less drops, one had more drops, but look at the outcomes. Less visual field worsening, less need for surgery. So it's not about only the pressure, it's about how stable the pressure is, and is it kind of long-term stability. And that's what we're seeing more now, and we're appreciating that more now.
Well, I think an interesting question from some of our participants, and something that I think is very pertinent, because the LiGHT trial, as you said, it was people who were newly diagnosed and had never had any kind of treatment. A lot of the people who are participating in our meeting have glaucoma, may have had treatment for many years with drops. So one of the questions in their mind is, okay, who's eligible for SLT? If I've been taking meds for years, should I try SLT? If I'm on 3 meds, would it make sense to try SLT to maybe get rid of one of those meds? So how do you present this? You know, I think it's pretty clear that for a newly diagnosed patient, you know, the only reason a newly diagnosed patient wouldn't get SLT is that the doctor doesn't like it, I guess.
Yeah.
But for someone who has been under management for many years, how do you treat those patients? What do you recommend? And I realize we're kind of running out of time, but I think there are a lot of questions on that order. Maybe Gus, let me start with you. What do you do for patients that have been on meds for years, and now you're looking at maybe a second or a third med? Would you offer SLT to those?
If you're looking at a second medication, then I would be offering, if they've had a prostaglandin, say, or a beta blocker for many years, I would be offering SLT to, if I first met them, if their pressures were uncontrolled, I'll be offering medication. Rather than adding extra medication, I will give them laser. If they're already on 3 medications and their pressure control is not good enough, then I really don't think that laser has a high probability of success. and they're probably going to be better served by having some form of surgical intervention. Mm-hmm. That's not to say that if you take 100 patients where they're uncontrolled on 3 meds and do laser, none of them are going to work. It's just, I think the percentage chances of it working are small. Now, some people will say, look, do the laser because it's safe before you do my surgery, because surgery's got bigger risks. And other people will say, let's not waste time. Let's just get on with it. I don't want to waste 3 months waiting to see if the laser works. Let's just get on and do the definitive surgery. And that's very much a more nuanced decision. But fundamentally, I think once you're already uncontrolled on 3 medications, you probably should be having surgery. But if you've had latanoprost for 3 years and you fancy getting off it, well, then laser's a great opportunity and works very well. If you're on latanoprost and it doesn't quite cut the mustard anymore, it's not quite, giving you a sufficient pressure control on its own, topping it up with laser may well be all you need. And I do that a lot.
Yeah, that's I think very helpful. Paul, you agree, or any differences in what you do for these types of patients?
I agree with Gus. I would just kind of add, I think it comes down to what is your goal? And that's the most important thing. Sometimes our goal in some patients is not to get the pressure even lower. As Gus mentioned, if you're controlled on 3 medications officially, but you're having a hard time taking them, right? And you're having compliance issues, well, yeah, maybe a laser is a great option. Maybe get you off that one. Or sometimes I've been surprised. I've gotten off of more than 1 medication because patients were not taking meds. They were non compliant. They had dry eye and all the stuff we talked about. But if, as Gus's point was really well said, is if you have, they're on 3 or 4 meds and your pressure's, upper 20s and you're, getting worse, you're probably going to want to do something more definitive, as you mentioned. So I think it depends on, are you controlled or not? What's your goal? And what's the relative contribution of being non-compliant? Patients coming in without, with not taking medications every day, I'm definitely worthwhile saying, let's try this first, especially if they're not advanced glaucoma, and see what happens and then decide from there. So I think I'm along the same lines as well, but it has to do a lot with what's your goal and where you at.
Very much so. Yeah. No, I think that's a nice explanation of it. There's one thing in the chat which I thought I'd jump if I may, which is
sure.
From Hugh Dannenberg, quoting a paper, Real World Outcomes of SLT in the United Kingdom. I've got to be polite about this because it's one of my friends and colleagues who wrote that paper, but it's a terrible paper. It was written by a drug company. Four of the authors were drug company employees. And if the first author's listening to this, I'm really sorry, don't kill me. But it took a lot of the patients in that paper were lost to follow-up. They didn't have, half the patients didn't have the follow-up length of follow-up that they talk about in the summary bit of the paper. But also it's pre-LiGHT trial. So these were patients, a lot of these patients were last-ditch attempts. These were people where they hated the medications, they were heading for surgery, they had probably had multiple bad reactions for many years, and they were a real sort of ragtag bag group of patients who were often having it just before they needed surgery. So it was hardly surprising that they didn't do well, because they're not the group that we think will do well. So it's a very different group of patients. And I think it's done patients, that paper has done patients a lot of harm, because it's really said that, hey, maybe laser doesn't sowed a seed of doubt in people's mind. And to be honest, I don't think that's what the data show at all. And I think I was surprised it was published where it was, but let's leave it at that.
So I'm sorry, go ahead.
No, I was going to say there's a number of other papers on first-line SLT that have been published before, and Dr. Katz has done great studies as well. Jim has done studies, and others. So I think the LiGHT trial took it to another level in terms of the data, the quality of the data, and the follow-up. But before that, for many years, there were great data sets out there that showed us that SLT primary therapy works very well and has good efficacy longer than 1 year for a lot of these studies.
Yeah, I mean, there's lots of great data out there. I mean, there's a danger that I get very excited about my trial, but there's loads of good data that made us want to do this trial. We were almost not asking the question, does it work? We were sort of asking the question, should we be doing it? And if we should, well, why is no one doing it?
Well, it is expensive to do a large trial like that, and to do it with the rigor you did is not easy. So I think it's a real compliment to you and your team for for the shift that is occurring, right?
Yeah.
No pun intended, but right before our eyes, we are seeing a significant shift to using SLT first. One other quick question is, do you think there's any age issue? I mean, a young person who's going to live with glaucoma a long time versus an older person who may not live as long with the disease. Is there any age restriction in terms of using SLT, or is that not a factor?
I don't believe so, no. Your target pressures may not be as low because you may be able to tolerate a very slow rate of decline in somebody who's 89 that you wouldn't tolerate in somebody who's 49. I mean, if you're as young as Paul, you know, you can't tolerate any kind of loss, you know. And an 89-year-old will say, most 89-year-olds realize that they're unlikely to be around for 30 years. There is a difference with age in terms of your target, but I don't think there's a difference in terms of whether you can use laser or not. In fact, I did laser on somebody yesterday who was in fact 89. She was having side effects from drops. I really don't want to do surgery for her if I can avoid it. She's still driving. She's still working as an academic. And so we did some laser.
Now, what about the other side of the spectrum? Is SLT indicated for congenital glaucoma or for juvenile glaucoma?
I would say no.
I'm
certainly
sorry.
Not congenital. Certainly not congenital. Juvenile. I have very little experience of using it in juvenile. The pressure is normally so high that you're normally heading for something else.
Yeah,
Paul, I mean, you've got a broader age range in your practice, I think, than I have.
Yeah, no, I think you're absolutely right. Congenital, I think you're talking about, you know, kind of goniotomies and trabeculotomies more than you would for in juvenile. It is sometimes the anatomy is a little different as well with some of these secondary glaucomas. So it's not as something I commonly would do. But I just want to kind of dovetail with a question you had before, because it's really important to understand age is not, I think, a differentiation, but it's the kind of severity of the outflow system. Meaning, if someone is young but has been on drops for, you know, let's say 20 years, right? Or let's say has advanced glaucoma where we think there's kind of significant scarring along the pathway, that may not work as well versus someone who is 89 who just developed glaucoma recently and still early. That, you know, patient might do better than a younger patient. So it's not necessarily age, it's more severity. And we don't know, unfortunately, one of the reasons why there's a 20% that may not function as well or may not have efficacy. We don't know where the resistance is, where we think it's at the meshwork I was talking about, but it could be distal, like downstream, so to speak, and that we don't know. And so this is why we have to try it, because it's so safe. Try it. If it doesn't work, we always have other options.
Yeah. Well, and I think in terms of trying it, that's always one of the questions too, is what do you do if SLT doesn't work? What's the downside? And I think, at least from my perspective, there isn't really a downside. You just do what you would normally do, perhaps with drops. And I think the other important point is that drops only usually work in about 80% of the cases. So it's very similar. You try one drop, you may have to try another drop. It's very similar.
Yeah. Yep. I mean, and don't forget that when we're saying in the LiGHT trial that 70% of eyes were controlled to target, that's not saying that the laser worked in 70% of eyes. It worked in more than 70%, but it wasn't quite enough in the remaining 30%. The remaining 30%, they needed to be topped up with something else. But that 30%, the laser was still doing something. So the total drop burden, even in the 30%, is less. Yeah. So,
good point.
You know, there may be that, you know, there's a proportion, I forget what it is, there's a proportion of the 30% who are on single drops who might otherwise have been on 2 or 3. So I think you're right. I mean, try it. Even if it's not enough, I don't think you're losing anything. I think it's a very, by and large, an extremely safe procedure. There's one question there on pigment dispersion syndrome. Pigment dispersion, I tend to use drops first, not because I'm worried about pigment dispersal, but because I'm worried about a very high pressure rise from the laser. So I do it very carefully. I just do very low power, and I normally do 180 degrees or less at a time.
And which type of patient is that? I'm sorry, Gus.
Pigmentary glaucoma.
Oh, yeah.
Yeah.
Well, thank you both. I think we're probably, because of time, just going to thank you for the wonderful presentations and for the great discussion. And
Thank you.
certainly, if we were unable to answer questions that were presented by some of the participants, we do encourage you to visit our website, just www.glaucoma.org. And there, I think there's a Q&A box there. You can put in your question and hopefully get answers and certainly learn about our research. So I want to thank you all for joining us today. Because of your continued partnership, the cure is truly in sight. Thank you all very much.